Bismillahirrahmanirrahim. So, continuing with the concept of Valerian degeneration, before continuing, I would like to pay my heartfelt thanks to Dr. Moeen, who has given me kind permission to record these sessions from his book. So, injury to the Valerian degeneration. Injury to the axon will result in Valerian degeneration. Valerian degeneration is a very peripheral concept, that is, it is happening in the peripheral nervous system, and it allows the regeneration of the neurons if there are suitable conditions. So, it occurs in the segment of the axon that has lost connection with the cell body. Degeneration of the axon and myelin distal to the point of injury will take place, and within a week, the axon is destroyed and its fragments are digested by the Schwann cells and macrophages. Similar degeneration occurs in the segment of axon that lies proximal to the injury. Degeneration of the proximal segment extends to the closest node of Ranvier. Allows for the potential regeneration of the axon if in the peripheral nervous system. There is a Uworld point. Axonal regeneration does not occur in the central nervous system due to the persistence of the myelin debris, secretion of the neuronal inhibitory factors, and the development of the dense glial scarring. Macrophages remove the debris and myelin. So, very first thing that you must remember, if I draw a hypothetical neuron over here, suppose this is the cell body, and then we have the axon, and after the axon we have this axonal terminal, and since it is a peripheral neuron, so it is covered by Schwann cells, and between the Schwann cells we have nodes of Ranvier. Like if I label them, so these are the nodes of Ranvier, and these cells are the Schwann cells, right? So these nodes of Ranvier. Now suppose the injury is happening at some particular point over here. Suppose the injury has taken place over there. So what is the concept of distal and proximal? That is very important to be learned. So that if I say that this is the point of injury, then everything towards the axon terminal is distal to the point of injury, and everything towards the cell body, this is the cell body, towards the cell body is proximal to the site of injury. First thing. Secondly, whenever there is an injury, the connection between the axon and the cell body, like this is the cell body and this is the axon, the connection is just cut off. When the connection is being cut, so there will be degeneration of the axon distal to the point of injury, and there is a catch over here. One segment proximal to the site of injury is also undergo degeneration. Like one node of Ranvier, like this is the node of Ranvier, this will also undergo degeneration because of some reason. Now the point of injury is very important because suppose we were talking about the point of injury at this particular point. If I shift the point of injury from here, just give me a second. Yes, from here all the way over here. Like suppose this is the point of injury now, and as per rule, there will be degeneration of everything distal to the point of injury, and one segment proximal to the site of injury is the cell body that will also undergo degeneration. So regeneration will not occur because we need the cell body for the process of regeneration. If the cell body has undergone degeneration, there will be no Valerian degeneration process, there will be no regeneration of the nerve, of the neuron in the peripheral nervous system. I hope this point is clear to you. Now let's move on to the next point. So there is a diagram, yes, so there is this diagram in which they have shown this thing over here. So suppose this was the site of damage. Distal to the site of damage, we have myelin debris accumulation, microglia are infiltrating, and everything is undergo degeneration. That is called as Valerian degeneration. Proximal to that, we have axonal reaction, and in the cell body we see chromatolysis. The chromatolysis is a complex of findings in which we have round cellular swelling, like the cell undergoes swelling, displacement of the nucleus to the periphery, which is supposed to be central. Now this central nucleus has gone to the periphery all the way over here, right? I hope this concept is clear. Then dispersion of the Nissl substance will also be seen. Then there is a point about the Uworld. CNS tumors of the neuronal origin and frequently stain positive for the synaptophysin on immunohistochemistry. You must remember the point that if I am talking about a glial tumor, so that will stain positive for GFAP. If I am talking about a neuronal tumor, so that must stain positive for synaptophysin. Like this synaptophysin positivity is seen in the neuronal tumors. Synaptophysin is a protein that is found in the presynaptic vesicles of the neurons, neuroendocrine, and the neuroectodermal cells. So neurons, neuroendocrine cells, and the neuroectodermal cells. So from here you must remember that if there is some neuroendocrine tumor or the APED tumor, that is for example small cell carcinoma of the lung. So small cell carcinoma, there is a neuroendocrine tumor, or maybe if I am talking about the carcinoid tumor, both of these tumors are neuroendocrine tumors, so they will also stain positive for synaptophysin, as well as there is another tumor marker called S100 and stuff like that. So we'll talk about that later on when we talk about these individual tumors. Moving forward, There is the Uworld point in the peripheral nervous system. We have Schwann cells. So there they have tried to depict why the regeneration process occurs in the peripheral nervous system and does not occur in the central nervous system. So in the peripheral nervous system, the Schwann cells sense the axonal degeneration and begin to degrade their myelin and secrete cytokines and chemokines that recruit the macrophages. This allows the effective clearance of the myelin debris, which along with the trophic factors secretion by the Schwann cells stimulate the formation of a growth cone from the stump of the proximal axon and facilitates the nerve regeneration. In the central nervous system, phagocytic macrophages and microglia are recruited more slowly because of the blood-brain barrier. Myelin-producing oligodendrocytes also become inactive or undergo apoptosis and do not assist with the phagocytosis. This slows the removal of myelin debris, which can persist for years in the degenerating tracts and suppress the axonal growth via myelin-associated inhibitory factors. Astrocytes also release inhibitory molecules and proliferate in the weeks to months following the injury, forming a glial scar that acts as a barrier to the axon regeneration. The next point is neuron action potentials. Resting membrane potential. The difference in the the resting membrane potential is the difference in the charges across the cell membrane at rest. There is a difference in the charges across the cell membrane at rest. This prevents the free diffusion of the ions. Typically, an excess of positive ions outside the cell and excess of negative ions inside the cells, giving rise to the electrical potential difference that ranges from minus 60 to minus 80 millivolts. Typically, it is minus 70. So, what is the trying to tell you is that suppose here I'm drawing the axon, right? Okay, before axon, let's draw a cell body. Like suppose this is a cell body and then we have an axon and then there is an axonal terminal. If I magnify this particular thing over here, so it will look something like this, that this is the axon, and in this axon, let me remove this thing. In this axon, we have excess of positive charges which are clustered outside and excess of negative charges which is clustered inside. So, very first thing that you must remember is that positivity and negativity is a very relative term, right? When we say that the point A is positive, it is positive. If I am saying that the point A has a positive charge, give me a second. So, if I am saying that this is the point A that has a positive charge, so it is positive in reference to some point B, some other point that is more negative in comparison to that. Like if there is point B that is less positive, this we never say anything that there is nothing like an absolute positivity or absolute negativity. There is this point A is more positive than B, so we have to use it relatively. We have to compare it with some other point that is less positive or more negative. I hope I'm not confusing you. So this is just like people, right? If I'm saying that the Mr. A is a good person, so he is more good, he is better than person B. Like person B is less good than person A. So this is a relative term. This is the concept of relativity which we see in the case of charges whenever we discuss them. So why is the outside of the cell more positive? We know that there is excessive positive charges outside the cell. The most predominant excess of positive charge is sodium that is present outside. And how does sodium come out? There is a sodium potassium ATPase present in the cells which pumps 3 sodium outside for every 2 potassium which are pumped outside. So now here you can see that there is more positive ions outside in comparison to inside. This makes the inside less positive, which we can say negative, right? So the inside of the cell is less positive in comparison to the outside. So this is the concept of charges, and charges are not evenly distributed. Neither can these charges diffuse across the cell membrane, because cell membrane is a selective permeable membrane. It is made up of lipids and it does not allow the charged molecules to move across freely, right? And if it does not allow them to move across freely, so this means that there will be dispersion or dissociation of the charges on the surface of the cell membrane, which allows effective impulse transmission. So it is caused by the efflux of potassium, high conductance of the, okay, so there is an important point that I was missing, but let's read it first. There is efflux of potassium, high conductance, EK is minus 80 millivolts, leak of potassium with some influx of sodium, low conductance, ENA of plus 60 millivolts. Potential maintained by sodium potassium ATPase and chloride contribute little to resting membrane potential. So here we have talked about sodium potassium ATPase pump. And other thing that we have to discuss whenever we are talking about the action potential is potassium leak channels. The potassium that is already present inside a cell and it is less in quantity than the sodium, it also leaks out. When the potassium is leaking out, that potassium leakage will adds on to the negativity on the inside of the surface. So now let's come back. There is also some contribution of the chloride channels, but that is very minute contribution, so we can ignore that. The main contributor is sodium potassium, and sodium potassium pumps are the main regulators of that. To depolarize, sodium channels open. It allows the sodium into the cell and raise the voltage. Sodium channels open along the axon, then it is propagation, and at the axon terminal, calcium channels open. They trigger the release of neurotransmitters. Vesicles fuse with the membrane, and there will be exocytosis. Now it is a very easy concept. Let's suppose I was talking about axon. So suppose this is an axon, and on the surface of axon, the positive charges are outside and negative charges are inside. But on the surface, we also have sodium, potassium, ATPase, sodium, potassium, ATPases, and sodium channels are also present. Right? There are the voltage gated sodium channels. The voltage gated sodium channels, as soon as the cell reaches the threshold potential. How is it reached? We'll see that later on. But as soon as the cell reaches a threshold potential, the voltage gated sodium channels start opening and the sodium starts rushing into the cell. This sodium, depending on the positive charge, starts coming into the cells, and each sodium that is coming into the cell, sorry, each sodium that is coming into the cells will cause the opening of the subsequent sodium channel. Like this will cause the opening of this, and then this will cause the opening of this and this. So this subsequent opening of the sodium channel across the axon will lead to the propagation of action potential on the surface of the axon. The next point is as when ultimately the impulse reaches the axonal terminal, there are special calcium channels which are present over here, and these calcium channels will cause the calcium influx into the cell. This calcium will fuse with the neurotransmitter vesicle, and this will help the neurotransmitter vesicle to fuse with the cell membrane, and this fusion will cause the release of the neurotransmitter into the synaptic cleft. So, this is the whole mechanism. I thought this will come later on as well. Now, let's move on to the picture. I guess it is taken from the Uworld. So, initially, the resting membrane potential is minus 70 millivolts, that is maintained by the sodium potassium ATPases, to some extent by the chloride as well. When the threshold potential is reached due to some reason, maybe there is some impulses which are coming, or maybe there is some, mostly it is because of the impulses of some mechanical factor as well. So when that threshold potential, that is at minus 55 millivolts, that is reached, there is a rapid entry of sodium into the cell by the voltage gated sodium channels. Remember, we are talking about right now we are talking about the nerve impulse conduction. So nerve impulse conduction is happening predominantly by the sodium ions. These sodium ions take the potential all the way up to plus 30, and this is called as the peak overshoot. Then after the overshoot, there is repolarization because of opening of the potassium channels, and because of that opening of the potassium channels, the potassium starts moving into the cells, and that uh, potassium that is moving into the cell, no, that is the potassium that is moving out of the cells. The potassium is leaving the cells, which is making the cells more and more negative. Yes. So potassium repolarization happening because of the opening of the potassium channels, and there is hyperpolarization, just like the offshoot of the depolarization. And then ultimately the sodium potassium ATPase will maintain the resting membrane potential. Here you can see that initially there is sodium permeance. The purple line is the same diagram as before. The purple line is the same. The peak in the purple line is maintained by the sodium permeance, that is into the cells. When the sodium is entering into the cells, and the remaining downslope of the curve is given by the sodium potassium permeance, and potassium is leaving the cells. So as a whole, the net result of these two curves of sodium entry and potassium leaving the cells is a graph like this, and initially there is depolarization, and that is followed by the repolarization, hyperpolarization, and ultimately resting membrane potential. Now let's talk about the clinical relevance of the action potential. Agents that block the sodium channels will inhibit the signal, and they will inhibit the depolarization. So if we have to give some if we want someone's brain to function at a lower rate, at a lesser rate, if we want to slow down the brain, we have to give sodium channel blockers, as we give with the local anesthetics, right? If we want to slow the impulse propagation, basically not slowing down the brain, if we have to slow down the impulse propagation across the axon, so we have to block the sodium channels, and we do that by giving the local anesthetics like the lidocaine or the benzocaine, the tetracaine, the cocaine, etc. Some neurotoxins also block the sodium channels, right? So the voltage gated sodium channels, these are some toxins which do that. Number one is tetrodotoxin, for example, the pufferfish. Then sexy toxin, dinoflagellates in the red tide. So they bind the sodium channel, inhibiting the sodium influx and preventing the action potential conduction. Cigotoxin, that is exotic fish, and moray eel, and the batrachotoxin, that is South American frogs. They bind the sodium channel, keeping it open and causing the persistent depolarization. Then here you can see axonal transport. So kinesins and dynein are microtubular motor proteins responsible for the rapid axonal transport. They are responsible for the rapid axonal transport. Kinesins participate in the anterograde transport, that is moving the intracellular vesicles and organelles towards the plus or rapidly growing end of the microtubules. Anterograde transport is usually directed away from the nucleus down the axon towards the nerve terminal. Then there is dynein. Dynein participates in the retrograde transport, it moving the organelle towards the nucleus. Dynein also functions in the ciliary and the flagellar movement. These two proteins derive the energy from the movement for movement from the ATP hydrolysis. So suppose if I draw a neuron over here like this. So sorry, if I draw a neuron over here like this and like this. So in this neuron, the anterograde movement will be towards the axonal terminal, and that is mediated by the kinesins. The retrograde movement will be towards the cell body, and that is mediated by the dynein. And very beautiful example of the retrograde transport is the movement of some viruses, for example HSV, and for example rabies virus. So they travel retrograde, and that retrograde transport of these viruses is mediated by the dynein motor arms. These dynein motor arms are also these dynein motor arms are also playing some role in the microtubular assembly. So moving the intracellular vesicles and organs towards the plus end of the microtubules is function of kinesins, and the dynein also function in the ciliary and flagellar movements. Okay. Now moving forward to the next point, that is about the astrocytes. Most common glial cell type in the central nervous system is the astrocytes. Remember that. What are the functions of astrocytes? They provide the physical support and repair, extracellular potassium buffer, removal of excess neurotransmitters. They are component of the blood-brain barrier. Glycogen fuel reserve buffer is also, they also act as a glycogen fuel reserve buffer. Reactive gliosis or hypertrophy and hyperplasia in response to neuronal injury can also take place. They are derived from the neuroectoderm. Astrocyte marker is GFAP, or the glial fibrillary acid protein. So here you can see a picture of the astrocyte, but it is very low yield. The high yield points are reactive gliosis, which you must remember because it is very important concept, and that shows on the boards most often. Then we have the clinical relevance. Astrocytoma. The clinical relevance of astrocyte is the formation of astrocytoma. They develop in the cerebellum of the children, and the GFAP positive. JC virus infects the astrocytes and oligodendrocytes. It is very rare virus, but if anything is rare, it means it is very high yield for the step exams. So the JC virus infects the astrocytes and oligodendrocytes, and they can cause promyelocytic leukemia in the HIV patients. Then what is microglia? Microglia are CNS macrophages. They are phagocytic scavenger cells, and they clean up the injured areas. Mesodermal and mononuclear in origin, activated in response to tissue damage. They are not readily discernible by nasal stain. HIV can persist in the brain via microglia. HIV infected microglia fuse to form multinucleated giant cells in the central nervous system. The next point is about the ependymal cells. The glial cell with a ciliated simple columnar ciliated simple columnar form that line ciliated simple columnar form that line the ventricle and central nervous system of spinal cord. So ependymal cells are present inside the ventricles. They line the ventricles. Suppose ventricles, if I'm talking about the ventricles, so there are 4 ventricles. There is one lateral ventricle and another lateral ventricle. Both of them are connected to the third ventricle by the foramina of Monro. Then the third ventricle is connected by a cerebral aqueduct of Sylvius to the fourth ventricle, the diamond shaped ventricle, and then that diamond shaped ventricle is connected to the central canal and by the foramina of Luschka and Magendie to the cerebrospinal fluid. If this whole talk about the ventricles is very Greek to you, so just forget about that. We'll talk about that later when we talk about ventricles. But right now I just want to make a point that that all the ventricles, if I'm talking about these lateral ventricles, so in the walls of these ventricles we have the lining of the ependymal cells. These ependymal cells are lining these ventricles, and one thing, they form the blood-brain barrier over there. Secondly, they secrete the cerebrospinal fluid. So let's see that. So they are saying that apical surfaces are covered by cilia which circulate the cerebrospinal fluid, and microvilli which help in the cerebrospinal fluid absorption. Okay. Then increase the speed of I'm sorry. So the function of the ependymal cell is that their apical surfaces are covered by cilia and they help to circulate the cerebrospinal fluid and the microvilli which help in the cerebrospinal fluid absorption. Now another important thing is that ependymal cells alone are not producing cerebrospinal fluid. There is a thing that we call choroid plexus. Just give me a second. There is a thing that we call choroid plexus. Now choroid plexus is a complex in which we have blood vessels, the ependymal cells and some other cells which collectively filtrate the cerebrospinal fluid, which collectively filter the cerebrospinal fluid from the plasma into the cerebrospinal, into the ventricles. So that thing is happening, so you must remember this point. Then about the structure of the ependymal cell, they look something like this. Like there are cilia on the surfaces and these cilia are responsible for helping in the circulation of cerebrospinal fluid. And the other thing about them is that there are microvilli present on the surfaces which help in the CSF absorption. Myelin, that increases the speed of impulse propagation in the axon. There is the concept of saltatory conduction. At the nodes of Ranvier, where there are high concentration of sodium channels, they allow the depolarization to jump from node to node. Only need to depolarize the node of Ranvier. No, do not need to depolarize the entire axon. This makes process faster. That increases the conduction velocity, and if the conduction velocity is increased, there is an increase in the length constant or the space constant. It seems somewhat paradoxical, but it is very logical if we consider it. A measure of how long the depolarization signal can propagate. If I'm talking about the length constant, so length constant means how long the impulse will be transmitted on the I'm sorry, the length constant means the length of the axon that is covered by an impulse before dying out. That is called the length constant. So higher the length constant means better impulse propagation. So we require or we need or we want to have a high length constant. It is a measure of how long the depolarization signal can propagate. If there is demyelination, suppose, for example, we see demyelination in the case of multiple sclerosis or the Guillain-Barré syndrome. So in demyelination, the length constant will be decreased due to increased charge dissipation across the nerve axon. Then there is the concept of time constant. We'll see that later on. But let's talk about one thing, that saltatory conduction. So saltatory conduction is, suppose there is a neuron, and this neuron, if the impulse has come to this neuron from the dendrites and then across the cell body, it has to move all the way on this axon. So when moving across the axon, we know that there is movement of positive charges into the cell and negative outside the cell. So basically that impulse propagation, as we have seen previously, is happening. So those charges have to move a very long distance all the way to the terminal axon before going to the next axon, next dendrites. So this whole process can result in the charge dissipation. Suppose the positive charges which are present over here, they may not stick over there and they start moving somewhat away from the axon, right? There may be charge dissipation, and if there is charge dissipation, okay, so if there is dissipation of the charges, so that dissipation will make the impulse conduction less efficient. We don't want that to happen. So as a solution to that, we have nodes of Ranvier. Like suppose this is the axon and these are the nodes of Ranvier. And now when the impulse in a myelinated neuron has to travel, all it has to do is to come from the dendrites on the cell body. Then it moves from one node to another to another to another. It starts jumping from node to node. It is not covering the whole length of the neuron, it is covering only the nodes. And if the nodes are covered only, the whole process becomes very fast and very efficient, and this is all we need. Right? This is the concept of saltatory impulse. Then we have discussed the concept of length constant as well, and now moving on to the time constant. So the time constant is over here, decreased time constant, the time it takes to change for a change in the membrane potential to achieve 63% of the new value. So it is just, think about it. Whenever we are talking about fast nerve conduction, what do we want? We want a longer distance to be covered in a smaller value of time, right? So if I'm saying about you know velocity is equal to distance covered per unit time. There is a formula that you may have come across when you used to study physics. So if the distance covered by time is equal to velocity, if I am increasing the velocity, so definitely I have to increase the distance. And if I have to increase the velocity, I have to decrease the time it takes to cover from point A to point B. So this is the concept that we apply on the neurons as well. So if we are trying to increase the velocity by myelinating the axons, the length constant will increase and the time constant will decrease, right? And the reverse is true when we are talking about the pathology related with the demyelinating conditions. Lower time constant allow quicker changes in the membrane potential, thus increasing the axonal conduction speed. Demyelination would increase the time constant and lead to slower impulse conduction. Synthesis of myelin by oligodendrocyte in the central nervous system, including the cranial nerve 1 and cranial nerve 2. So, it is very important that there is a discrepancy between the peripheral and central nervous system. In the peripheral nervous system, the myelin sheath or the myelination process is taken place is happening because of Schwann cells, and in the central nervous system, the myelination is taken place by oligodendrocytes. So, oligodendrocyte in the central nervous system, including the cranial nerve 1 and 2. So, cranial nerve 1 and 2, which are basically the central nervous system tracts, they are also being myelinated by the oligodendrocytes. Schwann cells in the peripheral nervous system, including the cranial nerve 3 to 12. So, cranial nerve 3 to 12, they are proper peripheral cranial nerves, while cranial nerve 1 and 2, they are kind of parts of the central nervous system. So, they are also, they are also myelinated by the oligodendrocytes. So, there is a thing that is mnemonic corpse, CNS oligodendrocytes and PNS Schwann cells. They wraps and insulate the axons, increase the space constant and increase the conduction velocity. So remember, speed constant is increased, conduction velocity is increased, and the time constant is decreased. The time constant is decreased. Now let's come back over here. What are the nodes of Ranvier? They are the areas of discontinuation of the myelin. What voltage gated channels are concentrated in the nodes of Ranvier? They are voltage gated sodium channels, because these are the channels which are responsible for initiation and then propagation of the impulse across the length of the axon. What is the function of these channels? They provide a saltatory conduction, speeding up post conduction. What happens to these channels in the individuals with the demyelinating diseases? They will not be concerned. They will not be concentrated in the nodes of Ranvier, but they will spread all over the axon, slow down the impulse conduction. They will slow down the impulse conduction. Now, what are Schwann cells? Each Schwann cell myelinates only one peripheral nervous system axon. They also promote the axonal regeneration derived from the neural crest and injured in the Guillain-Barré syndrome. So this is the Schwann cells. Schwann cells have these are Schwann cells and they are node of Ranvier, where these are the points of disruption or discontinuation of the myelin, and these are the myelin sheath. As you can see that the myelin sheath is wrapping layer by layer over the surface of the axon. Now here you can see that myelin is being wrapped on the surface of the axon, and here we have the nucleus. So let's come back. Oligodendrocytes, the oligodendrocytes myelinate the axons of the neuron in the central nervous system. The optic nerve is the only cranial nerve that is myelinated by the oligodendrocytes, so it is affected in the multiple sclerosis. Each oligodendrocyte can myelinate many axons, about 30. Predominant type of glial cell in white matter. They are derived from the neuroectoderm. Fried egg appearance histologically. So the oligodendrocytes have a fried egg cell appearance. There are some tumors associated with oligodendrocytes which are called the oligodendrogliomas, and they also have fried egg appearance when we see the histology. Injured in the multiple sclerosis, progressive multifocal leukoencephalopathy, and leukodystrophies. Then over here we can see this is a node of Ranvier. Then we have the axon and the oligodendrocyte over there and stuff like that. Moving forward to the types of nerve fibers. There are different types of nerve fibers. Classification by diameter are 8 alpha fibers, the 8 delta fibers, the C fibers, and then we have stuff like that. So the A alpha fibers are the large myelinated fibers, 6 to 15 micron diameter large. We have most efferent motor fibers, touch, vibration, and position. A delta fibers, they are small myelinated fibers, 3 to 5 microns in diameter, and they are responsible for sensation of the cold and pain. The C fibers are unmyelinated fibers, 0.5 to 2 microns in diameter. They will detect the warmth and pain, and these small fibers are most easily blocked by the local anesthetic. Then we have the next point about the sensory receptors. The sensory receptors are very high yield, so you must remember these things. Now free nerve endings, C type fibers or slow fibers, they are unmyelinated fibers. The A delta fibers are fast myelinated fibers. So the free nerve endings can either be C fibers or A delta fibers. The C fibers will detect the slow conduction of the pain, which because the slow C fibers are unmyelinated fibers and the A delta fibers are the fast fibers, they are the myelinated fibers. The location is present in all the skin, epidermis and some viscera, and senses are pain and temperature. The mesener corpuscle, is large myelinated fibers and they adapt quickly. The mesener corpuscles are present on the large myelinated fibers and they will adapt quickly. They are present on the glabellars of the hairless skin and dynamic fine light touch and position sense. So the mesener corpuscles are responsible for the dynamic fine light touch and position sensations. Then we have Pacinian corpuscles. So Pacinian corpuscles are large myelinated fibers and they adapt quickly as well. The deep skin layer, they are present in the deep skin layers and ligaments in joints and they are responsible for vibration and pressure sensations. Then we have Merkel disc. The Merkel discs are large myelinated fibers and they adapt slowly. They are present on the fingertips and superficial skin. They are responsible for the detection of pressure, deep static touch, for example, shapes, edges, position sense. The Ruffini corpuscle, the Ruffini corpuscles are dendritic endings with capsule and they adapt slowly. They are present on the fingertips and joints and they are also responsible for pressure sensation, slippage of the objects along the surface of the skin, and joint angle change. The concept about the peripheral nerves. So the peripheral nerves contain three layers, which are endoneurium, perineurium and epineurium. So the endoneurium invests single nerve fiber layer. Inflammatory infiltrate in the Guillain-Barré syndrome. The endoneurium contains the inflammatory infiltrate in the case of Guillain-Barré syndrome. It is very important to remember that endoneurium will invest a single nerve fiber layer. Suppose uh, this is a nerve. So in a nerve, in a nerve we have the outermost covering that is called the epineurium, and then we have the perineurium, which is in a nerve. Okay. Let's come back. If this is a cut section of a nerve, there will be fascicles which are present all over the nerve, right? And in the fascicles we have multiple neurons, single nerve fiber like this and this and this. So the outermost covering is called as the epineurium, which is covering different fascicles of the nerve. The perineurium is covering individual fascicles. This is the perineurium, and if I highlight a single nerve, single dot that is present in the fascicles, this single nerve is covered by the endoneurium, and this endoneurium harbors or contains the inflammatory infiltrate in the case of Guillain-Barré syndrome. Perineurium, blood nerve permeability barrier. It surrounds the fascicle of the nerve fiber, like the fascicles are surrounded by the perineurium. In this discussion, we are moving from inside to outside. Firstly, we have discussed about endoneurium. Now we are talking about perineurium. So it surrounds the fascicle of the nerve fibers, must be rejoined in the microsurgery for the limb reattachment. Then we have epineurium. It is a dense connective tissue that surrounds entire nerve fascicles and blood vessels. So endo is inner, peri is around, and epi is outer. So this is a beautiful picture. Here you can see that the endoneurium is lining the individual nerve fiber. This thing is an individual nerve fiber. This with the Schwann cells and stuff like that. So the individual nerve fiber is lined by the endoneurium. Then surrounding the endoneurium we have perineurium, which is surrounding fascicles, and then epineurium. This is also a beautiful picture. Here you can see that this is a nerve trunk. The epineurium is surrounding everything. It is the outermost covering. Then we have fascicles which are being surrounded by the perineurium, and then we have the endoneurium that is surrounding individual nerve fibers. Coming to the next point, they are talking about the peripheral nerve damage. We have talked about that when we were discussing the Valerian degeneration, but now there the concept of neuropraxia, axonotomesis, and neurotomesis. So neuropraxia, it is focal demyelination. Axon distal to the injury is intact, continuity across the injury, and there is an excellent chances of recovery. Like I'm sorry, like this is the concept of neuropraxia, that the damage is on that the axon is intact, there is no damage to the axon. As you can see that this axon is continuous all the way. The point of injury is this, but this point of injury has not damaged or has not wreaked any havoc to the axon. So there is continuity of flow of exoplasm throughout the axon, so the recovery is very rapid and recovery is very profound in these cases. Then we have moderate, that is called as axonotomesis. There is demyelination plus damage to the axon. Demyelination plus damage to the axon. Endoneurium, perineurium will remain intact, but the axon is damaged. This is called as axonotomesis. Tomesis, you may say that tomesis means to cut down, right? So here you can see the Schwann cell is gone, the axon is gone, but the endoneurium, the perineurium and the epineurium, everything is intact. The endoneurium, perineurium, and they are intact. The only damage that has happened is axonotomesis, and there is some degree of regeneration that happened in this kind of nerve lesion as well. Then there is severe kind of lesion that is called as neurotomesis, and now the whole neuron is being severed or cut down. So axons, myelin sheath are irreversibly damaged. External continuity of the injured nerve is disrupted. There is no significant regeneration that occurs at this level of neurotomesis, and it has a very bad prognosis. So here you can see that we have the neuropraxia, axonotomesis, and neurotomesis. Then moving forward, the axonotomesis, if there is only neuropraxia, so the Schwann cell will regenerate and everything will be just fine. In axonotomesis, we have to regenerate the neuron by using Wallerian degeneration. And in the case of neurotomesis, the nerve does not regenerate in most cases. Now, the axonotomesis, distal to the lesion, Wallerian degeneration will occur. Axon degenerates, myelin sheath involutes. Axon regrowth sometimes occurs, possible if the Schwann cells maintain their integrity. Proximally, we see axonal reaction. The changes in the body of the neuron after the axon has been severed, also called as the central chromatolysis. Upregulation of the protein synthesis for repair. Cell body changes include cellular swelling, chromatolysis, which means disappearance of the nasal bodies, nucleus moves to the periphery and resolves with time. Variable prognosis, extent of damage, distance to the target, and complexity of the nerve, everything is playing its role in the prognosis seen in the axonotomesis. Usually there is partial recovery, longer recovery time than neuropraxia. So here you can see this is the normal. Then in the chromatolytic cell, the nucleus has been pushed to the periphery and the nasal substances have also been peripheralized along with the nucleus. In the regeneration, the things come back to the normal level. But this neuron, if you could focus, these are myelinated neuron. This neuron has yet to be myelinated. It is a very beautiful picture in which they have, these are normal neurons, like this one is a normal neuron. But here you can see that the nucleus and the nasal substances have been marginalized, and the rest of the cytoplasm of this neuron is very clear. Moving on to this point, central nerve damage. There is ischemia. 4 to 5 minutes of ischemia will lead to irreversible damage. Right? Remember, we are talking about the central nervous system or brain. So, if there is 4 to 5 minutes of ischemia, that will lead to irreversible damage. Neurons are more sensitive than the glial cells. There is higher energy demands and they lack the glycogen. Why the neurons are very sensitive? Because they have high energy demands and they also lack glycogen. Most sensitive neurons are okay, so neurons are in general very sensitive because of lack of glycogen, and to be very specific, even among the neurons, so the most sensitive are hippocampal neurons, then the Purkinje cells of the cerebellum, and the neocortex. Striatum, the basal ganglia are also very sensitive to ischemic changes. What are the changes after infarction? So in 12 to 24 hours initially, there are red neurons, eosinophilic cytoplasm, pycnotic nuclei, and loss of nasal substance. This will be seen. Macroscopically, we don't find any significant change in first 12 to 24 hours, but the red neurons will be seen in the microscopic level. Pycnotic nuclei and loss of nasal substance will be seen. In 24 to 72 hours, there will be neutrophilic infiltration, like in 1 to 3 days. Okay, so if I write it like this, so on day 1, on one day, there will be no significant change on the macroscopic level, but on the microscopic level we will find red neurons, right? And why do they appear red? Because they have eosinophilic cytoplasm and pycnotic nuclei, and they have loss of nasal substance and stuff like that. From 1 to 3 days we have infiltration of the neutrophils. From 3 to 7 days we have macrophage, microglia infiltration, and phagocytosis will begin. In 1 to 2 weeks there is reactive gliosis and vascular proliferation around the necrotic area. That will result in the liquefactive necrosis 1 week to 1 month, and more than 2 weeks there will be the formation of glial scar. Cystic area is surrounded by the dense glial fibers more than 1 month. So here you can see this is a picture of a red neuron. Then moving forward, we have the type of neuronal reaction to injury as summarized in the table. Acute neuronal injury, red neurons. The transient severe insult. The type of injury that caused the red neuron formation is the transient severe insult that leads to cell death. Histopathologic changes include shrinkage of the cell body, pycnosis of the nucleus, loss of nasal substance, and eosinophilic cytoplasm. Everything that we have already discussed. This is just a tabulated version of that. Axonal reaction means loss of axon. enlargement of the cell body, eccentric nucleus, enlargement of the nucleolus, dispersion of the nasal substance will be seen in that. Neuronal atrophy is the progressive degenerative disease. There is loss of the neurons and functional groups of the neurons, and there will be reactive gliosis. Now, neurotransmitters, for example, norepinephrine. Now, we'll talk about individual neurotransmitters, where they are found and what are their functions. So, norepinephrine, that is a stress or panic hormone. The increased level are seen in the cases of anxiety when the person is anxious, because norepinephrine drives your brain. And when there is excessive activity of your brain, for example, in the case of anxiety, we find high level of norepinephrine. Decreased level will result in depression, definitely. Some antidepressants, for example, increased norepinephrine levels like SNRIs are very good for that. Its main source is locus coeruleus in the posterior pons and near the fourth ventricle. Then the dopamine, it is synthesized in the ventral tegmentum, midbrain, and substantia nigra, that is also present in the midbrain. So location of synthesis of these neurotransmitters is very important and high yield for your NBMA exams, and even in the board exams they sometimes ask you questions about these things. So increased level of, there is an increased level in schizophrenia, decreased level in the Parkinson's disease and depression. Moving on to the next point, they are talking about GABA. GABA is the main inhibitory neuron of your central nervous system. So GABA is largely inhibitory, synthesized by the nucleus accumbens, that is present in the subcortex, important for the pleasure and reward. Research shows that it is activated in the drug addiction and fear, decreased level in the anxiety and Huntington disease. So Huntington disease has a decreased level of a lot of things, including the GABA. Acetylcholine level is also decreased in the Huntington disease, but we'll see that later on, inshallah. The GABA receptor anesthetics include etomidate, propofol, benzodiazepines, and barbiturates. These drugs activate the receptor, and that will result in sedation. Then we have GABA receptor. The GABA receptor GABA binds to its receptor and allows the chloride into the cells more negative membrane. So we have, when we were talking about the resting membrane potential, I said that chloride has a minute role in maintenance of the resting membrane potential or the action potential. So the chloride channel, suppose this is a channel, the chloride channel will shift the chloride from the outside into the cells, and since it is a negative charge, it will add on to the negativity that is already present inside the, on the inner surface of the cell. So suppose this is a resting membrane potential at stuff like that. So this is minus 70 millivolts, and we have to reach minus 55, right? That is threshold potential. So if chloride is entering the cells, the resting membrane potential will become more negative, and it will go all the way to minus negative 90. Suppose I'm just talking about hypothetical terms. These are not actual terms. I'm just giving you numbers which are hypothetical. So it is easier for a cell to reach from minus 70 to minus 55 than to reach from minus 90 all the way to minus 55. So the initiation of the nerve, initiation of the action potential, it becomes more and more difficult by the GABA stimulation or the GABA receptor activation, right? So then we have the GABA binds to the GABA receptor binds to the receptor, allows the chloride into the cells, and more negative membrane potential will make it harder to get depolarized and decreases the neuronal excitation, and that will make it inhibitory. GABA synthesis, synthesized by glutamate decarboxylase in the neurons, broken down by the GABA transaminase. Both enzymes need B6 as a cofactor. B6 is pyridoxal phosphate, and that is required for the synthesis of GABA and also the breakdown of GABA. Vitamin B6 deficiency will lead to seizures. Then we have chloride is entering the cells. The glutamate will be converted to GABA, and GABA will lead to breakdown products, so glutamate decarboxylase and GABA transaminases. Then we have serotonin. It is synthesized in the raphe nucleus and decreased level in the anxiety and depression. Serotonin syndrome can occur with any drug that increases the serotonin. For example, the selective serotonin reuptake inhibitors, monoamine oxidase inhibitors, SNRs and TCS. We'll talk about the individual mechanism of action when we'll go to these drugs particularly. But all of these drugs increase the level of serotonin, and that will result in the serotonin syndrome. Now, the serotonin syndrome is characterized by the presence of a classical triad. Number one is the mental status changes, for example, anxiety, delirium, restlessness, and disorientation. Then autonomic hyperactivity like diaphoresis, tachycardia, and hyperthermia, and neuromuscular abnormalities like tremor, clonus, hyperreflexia, and bilateral Babinski sign. Watch for the patient on antidepressant with fever, confusion, and rigid muscle. muscles. Don't confuse with the neuroleptic malignant syndrome. Both muscle rigidity, fever, changes in mental status and autonomic instability. So both the conditions like the serotonin syndrome and the neuroleptic malignant syndrome, they have the muscle rigidity and fever and changes in the mental status and autonomic instability. The neuroleptic malignant syndrome leads to lead pipe rigidity and increase in keratin kinase, and serotonin syndrome has clonus. So the differential will be seen when in the neuroleptic malignant syndrome we will find lead pipe rigidity with increasing keratin kinase exclusively with the NMS, neuroleptic malignant syndrome, and with the serotonin syndrome we find clonus, right? The treatment is with a cyproheptadine, that is a serotonin antagonist. Then acetylcholine, it is synthesized in the basal nucleus of the minute subcortex. It is decreased in the Alzheimer's disease and Huntington disease. Another neurotransmitter that was decreased in the Huntington disease is GABA. We have just studied about that a few minutes ago. And the acetylcholine level is decreased in the Alzheimer's disease. It is very important. So, increased level in the REM sleep. When you are in the REM sleep, rapid eye movement sleep, the acetylcholine level is increased. The next point is glutamate. Glutamate is a major excitatory neurotransmitter. N-methyl D-aspartate receptor is the target of the glutamate. Huntington's neuronal death from the glutamate toxicity. Glutamate binds the NMDA receptor, and excessive influx of calcium will lead to calcium-mediated cytotoxicity, and there will be cell death. Excessive entry of the calcium into the cell is cytotoxic, and that cytotoxicity is caused by NMDA activation by the glutamate. Then we have fencyclide in the PCP, that is called as the angel dust. It is an antagonist to the NMDA receptor. It is very important. It is an antagonist to the NMDA receptor. It is a it is an abusive drug, and it is an illegal drug. So antagonist to the NMDA receptor, it induces violent behavior, hallucinations, ataxia and nystagmus, hypertension, tachycardia and diaphoresis, and it can cause seizures, coma or death. The next point is acetylcholine, dopamine, GABA, norepinephrine, and serotonin. So this is a summary of everything that we have just discussed. So acetylcholine location is the basal nucleus of minute. It is decreased in the Alzheimer's disease, in the Huntington disease, and increased in the Parkinson's disease. We are talking about acetylcholine. Then we have dopamine. It is produced in the ventral tegmentum nucleus. So the very important thing, the very first thing is that it is decreased in the dopamine. It is decreased in the Parkinson's disease. So dopamine is decreased in the Parkinson's disease. Acetylcholine is increased in the Parkinson's disease. Secondly, the dopamine is also increased in the Huntington disease and in schizophrenia, and dopamine is also decreased in depression. So in depression and Parkinson's disease, we have a decreased level of dopamine, while in the case of schizophrenia and Huntington disease, the level of dopamine increases. Then talking about GABA, GABA is produced in the nucleus accumbens. It is decreased in the anxiety, and it is decreased in the Huntington disease. This thing that it is decreased in anxiety makes sense because in anxiety your brain is hyperactive, which means that the inhibitory neurons are inhibited. There is no inhibition of your brain, so the GABA level in the cases of anxiety is decreased. Then norepinephrine is produced in the locus ceruleus. It is increased in the anxiety, and it is decreased in the depression. Then we have serotonin that is produced by the raphe nucleus. It is decreased in anxiety and decreased in depression and also decreased in the Parkinson's disease. Moving forward to the meninges. Three membranes that surround them and protect the brain and spinal cord are the dura mater, arachnoid matter and the pia mater. Thick outer layer closest to the skull is the dura mater. It is derived from the mesoderm. Arachnoid matter is the middle layer and contains web-like connections, and it is derived from the neural crest layer. It is very important that the arachnoid matter is derived from the neural crest layer. The only layer to be derived from mesoderm is the dura mater. The rest of two layers, which are leptomeninges, are coming from the neural crest layer. Pia mater is thin, fibrous inner layer that firmly adheres to the brain and spinal cord, and that is derived from the neural crest cells. CSF flows in the subarachnoid space located between the CSF flows in the subarachnoid space that is located between the arachnoid and the pia mater. The epidural space, a potential space between the dura mater and the skull containing the blood vessels. So here you can see that this is the skull. Below that we have dura mater. Below that we have arachnoid mater and pia mater. Between the arachnoid and the pia mater, we have these web-like spaces across which there is subarachnoid space and CSF is present over there. Now here you can see that this is the dura mater, Just below the skull, then we have sagittal sinus. There are bridging veins, the arachnoid matter, the pia matter, and the brain is over there, and stuff like that. So we'll keep this session till here, and we'll continue with the blood-brain barrier in the next session. Until then, Allah Hafiz, fi amanillah, and take care.